am so pleased to be moderating this panel, and thank you all so much for joining us at Making Humanitarianism Human, a panel discussion on global health and healthcare delivery in the Arab world and beyond. And I just wanted to open up by touching on why I felt it was so critical to have a panel discussion on this topic at this conference today. This year's conference theme is Leaps of Faith, Reimagining Change. And it quite rightfully challenges all of us to think not only of those in the Arab communities and the Arab world who are at the cutting edge of business, politics, medicine, and the like, but it is also a chance for us to all take this opportunity to do more than connect and network with each other, but to also consider what each of us in this position and at different stages of our careers can give in return. And to start with a question from the late Dr. Paul Farmer, if access to healthcare is considered a human right, who is considered human enough to have that right? The aim of this panel is to take access to healthcare as a human right, as a given, and to do more than discuss health in abstract terms. We'd like to understand how healthcare delivery functions in vulnerable regions, particularly in the Arab world. And in the wake of the COVID-19 pandemic, amidst decades of political suppression, and more recently, following natural disasters in Syria and Turkey, the question of health system resilience is all the more pertinent. More importantly, we'd like to discuss health beyond the boundaries of humanitarianism and international governmental action. How do we collaborate with communities longitudinally, not only in the wake of disaster or in the midst of political strife or when the cameras are on, but in the long term? Where is there room to innovate, and where must researchers and organizers be resourceful? And lastly, and most importantly, how do we work with, not just for, marginalized peoples in the Arab world and beyond to create healthy futures for all? We are joined by three fantastic speakers representing a broad range of experiences in medicine, science, and activism, and whose clinical careers have branched out to encompass a mission to rectify global health inequities. So I'll just go down the line and introduce each of them, and then we'll get started with our discussion. So first, we'll begin with Dr. Maha Farhat. Dr. Maha Farhat is the Gilbert S. Oman Associate Professor of Biomedical Informatics at Harvard Medical School and a practicing physician in the Division of Pulmonary and Critical Care Medicine at MGH. Her research centers on characterizing infectious disease agents, particularly TB, with the aim of contributing to better approaches to control drug-resistant pathogens. The Farhat Lab at HMS collaborates with TB research efforts in South Africa and India to improve surveillance, diagnosis, and precision care for patients in diverse contexts. Her work, spanning from field research to computational genomics, seeks to find translatable and accessible solutions to reduce the global burden of infectious disease. Please join me in welcoming Dr. Maha Farhat. And next we have Dr. Bram Wispelwey. Dr. Bram Wispelwey is an associate physician in the Division of Global Health Equity at Brigham and Women's Hospital and an instructor at Harvard Medical School and the Department of Global Health and Population at the Chan School of Public Health. He is a co-founder of Health for Palestine, a community organizing initiative in Palestinian refugee camps that seeks to maximize wellness and address health barriers via social accompaniment and creative integration with existing facilities. His work and research focuses on intersectional and settler colonial determinants of health. Dr. Wispelwey is also a senior technical lead with Partners in Health United States and a senior fellow at the Atlantic Fellows for Health Equity. Please join me in welcoming Dr. Wispelwey. And we'll hear a bit at the beginning from each of these speakers about their work in their own words. And last but not least, we have Dr. Salman Khashoggi. Dr. Khashoggi is a professor of global health and social medicine at HMS and the director of the HMS Center for Global Health Delivery. An expert in infectious disease and medical anthropology, Dr. Khashoggi has led initiatives to treat multi-drug resistant tuberculosis in Africa. His work with the Center for Global Health Delivery focuses on community-centered interventions to address public health issues in the Middle East and North Africa. In partnership with the HMS Center in Dubai, the Center for Global Health Delivery works to improve healthcare access and implementation of high-quality treatments in under-resourced settings. Dr. Khashoggi has also worked with Partners in Health and the World Health Organization, and he is currently involved with the Zero TB Cities initiative, which seeks to eliminate tuberculosis in high-burden settings. Please join me in welcoming Dr. Khashoggi. And for sake of completeness, I'll introduce myself. My name is Leena Hamad, and I'm an MD candidate at Harvard Medical School. I hope my career can be even half as successful and impactful as any of the people on this panel today. But truly, they are exactly who I strive to be. I'm very passionate about global health, and I'm very excited to be leading this conversation today. I think it would be great to hear from each of our three speakers about their work and to hear a little bit about what the state of healthcare looks like in under-resourced settings, in the settings that you work in.
First of all, thank you so much, Leena, for putting this together, and for all of you for being here, and for this entire conference that I think is really quite inspiring, that we're all coming together to think about these things and discuss them. So from my point of view, my career path, I was actually born in Beirut, Lebanon, and I lived most of my childhood in Dubai, where I was very passionate about science and math. And then I went back to Beirut to pursue my undergraduate training at the American University. And there I continued to be really passionate about doing science and research, but found the opportunities to do that in the region to be pretty limited. And that's why I eventually went to McGill for medical school and initially wanted to do an MD PhD, but couldn't quite decide on the research field within the MD track at McGill. The options were more limited. So I ended up pursuing residency, and during residency and fellowship, I found my passion for tuberculosis research. And I found that the avenue that I pursued was really around epidemiology and molecular epidemiology. And the more I got deeper into it, the more fascinated I was with the use of data, different types, molecular and other types of data, to inform how we manage care, how we can develop better surveillance, diagnostics, and treatment modalities. And that's kind of where I am now. In my current research, I've been very interested in the use of sequencing, pathogen sequencing, for diagnosing antibiotic resistance, for kind of learning the biology of associations between the DNA mutations and the resistance phenotype. And I'm very proud to say that we've been able to translate some of that work to actually be used as a diagnostic, and we collaborate with the World Health Organization to create these guidelines on how to do that and how to actually implement the use of sequencing for diagnostics. And you might think, that this is a very technologically advanced, really complicated solution for a problem that affects mostly resource-limited settings. So how is that even possible, and how does it work? The reality is that technologically advanced solutions are actually sometimes the right solutions if they address a gap, and the gap is essentially otherwise completely void, and there isn't necessarily a good on-the-ground way to walk around the fact that, for example, TB is incredibly hard to culture, and we're never going to have lab facilities that actually are able to culture TB to sufficient capacity to address the needs of the region or of those communities. And so my work has been an implementation of that, and actually the use of sequencing for TB kind of as a biomarker for TB treatment monitoring. And in the context specifically to answer Leena's question around how does healthcare look like in the regions where I've worked. So I've done work actually with Socios and Salud Partners in Health in Peru as a postdoctoral fellow, and then later in India, as well as more recently in South Africa. And it's very variable what you see on the ground. I think there's a vision that resource-poor settings, have very little capacity, but the reality is that it varies quite a bit. I think we can think about it as kind of limited healthcare resources in terms of individual providers. There's limited access to diagnostics. There's limited access to treatments. And they are addressed in different ways in different parts of the world. For example, I found that, for example, in India, where I've done work, most of the TB healthcare is supposed to be managed by the public health sector, and the reality is patients avoid going to the public health sector because they prefer that people don't realize that they have TB because there's a lot of stigma in the disease, and so they end up pursuing care in the private health sector, and this ends up creating all sorts of challenges for the patients because physicians in the private health sector don't necessarily get the kind of training that they need to manage these cases. And actually, there's lots of evidence that patients can get really badly mismanaged by some providers in the private health sector. So I'm going to stop there because I'm not like an implementation researcher, and I'll let my colleagues here speak more about the context and resources in the context they've worked. Yes, go ahead.
So thank you so much, Leena, and such an honor to be on with Salman and Maha. So, and thank you all for being here. So I'll just talk briefly about how I got into this work, what it looks like, what the healthcare context looks like. And there's others here as well who could also chime in and do so. We have Drs. Tariq and Karama, my colleagues in Palestinian health. So I grew up in the United States, actually, and I don't have any family connections to the region at all. But after law school, my partner got a job working for Adalah, the Legal Center for Arab Minority Rights in Israel, based in Haifa. Essentially, we moved in 2010, and I studied medicine in the Naqab. And that's where I became a doctor. And soon after I moved there, there was a village, Al Araqib, about 10 kilometers where I studied medicine, that was demolished. And it's since been demolished over 200 times since. And that was my wake-up call as someone who was, fairly ignorant of the context in which I had just moved to what Palestinians were going through, had gone through, and continue to go through in terms of things that impact their health. Got connected to more and more people there, including Dr. Jumana Odeh in the West Bank. Her niece is here today as well, so this is really amazing. She was the first person I ever met. I sort of disobeyed my school's orders and went to the West Bank to meet her in 2010, and she started introducing me to the context of Palestinian health and Palestine more generally. And since then, I ended up coming back to the United States for my residency in internal medicine and global health at Brigham and Women's Hospital, working with incredible colleagues there who had done a lot of work to demand and ensure equitable care in various places around the world, and got connected through other friends and colleagues to refugee communities in the West Bank, specifically Aida Refugee Camp and Al-Azhar Refugee Camp in Bethlehem. And I've been working in solidarity with refugees ever since, mostly working around chronic diseases and the deep fragmentation of care that exists in the occupied territory. And so what that looks like, for Palestinians, for Palestinian health, really depends on where exactly you are in what's a very small geographic space, but differs quite considerably, right? So if you're a Palestinian citizen in Israel, like my colleague at the FXB Center, Dr. Osama Tanous, that means you have less access to care. You have a situation of access to care that's somewhat similar to communities of color in the United States today. If you're in the occupied West Bank, that means you have access, depending on maybe certain your wealth status and other things. You can have access to private care. There is the Ministry of Health under the Palestinian Authority, and for refugees, there's UNRWA, the UN, and a similar situation in Gaza Strip, more limitations. Many folks have to apply for care outside of the occupied territory, and frequently those permits are denied. And so you have a situation where many types of care are not available. Many of the care that is available has significant limitations, and all of this is what we could say structurally determined, right? It's politically determined. It's determined by things like settler colonialism, by what all major international human rights organizations now call apartheid, and an ongoing military occupation. So, what that looks like, we recently had a webinar with these people working in these communities, we're calling Health for Palestine, and Dr. Karama spoke really eloquently about what that looks like, for example, in Balata refugee camp. But I'll go ahead and stop there after giving some of that sense of where things are at, and let Dr. Khashabji go from here.
Thank you, Leena, for inviting me to be part of this panel. It's I got into global health. I started actually as an immunologist. I thought I was going to work on, I came to Harvard to work on a Leishmania vaccine. I did biochemistry undergrad. I was really working in the laboratory a lot. And I was supposed to go to Brazil one summer to do an immunotherapy trial for this Leishmania vaccine that we'd been working on. And it kind of fell through at the last minute, and I had this grant from the Canadian government. I'm from Canada. And at the last minute, I ended up going to Bangladesh and working with an anthropologist in a poor urban community. And it was this incredible eye-opener for me, because we were working there, and there were people that were taking shifts sleeping in these very marginal housing. And there was lack of water and lack of you just name it, lack of medicines, lack of water, lack of care, and the solution was we need to do more health education, and these community health workers who again were also sleeping in shifts, they were volunteers and they weren't paid, and then so we'd go there in the daytime and interview people and talk to them, and then we'd come back back to the central command place and have samosas and tea and hang out and all this. And at that point, I kind of was thinking, what is this? Because, why would we expect people who are ultra poor to work for free? Like even I, as an intern, am getting summer money. And why would, you can't educate people out of dirty water and a whole bunch of other things. You need access to these things. And so, I left that summer really looking at how late 20th century capitalism had really infiltrated the way we thought, and extractive capitalism had infiltrated the way we think about healthcare, but also who gets care, why do they get care, why is it structured this way in certain places and not other places. So I came back. I ended up leaving immunology. I went into anthropology, which was the best thing I ever did. And the Soviet Union had collapsed around that period. And I was able to go into Tajikistan, which borders China and Afghanistan, and work there, at a point where non-governmental organizations were just coming in. And it was an opportunity to really examine, the ideology that was being brought in by non-governmental organizations as transplant mechanisms, and really how that, jived with, how that was kind of docking, the capitalist aspects of it, docking with communism, docking with ideas about Islam, et cetera. So I ended up working on that. I ended up writing a book about that called Blind Spot. And then while I was there in these villages, there were babies dying, and I was of course writing notes copiously about it. And I thought, well, I can't just do that, can I? You kind of, if you're going to think about health and health delivery, it helps to be a doctor. So I came back and went to med school. So I ended up getting an MD, PhD, not in the traditional way, but by doing them separately. And along the way, I bumped into, my wife and I started working with Partners in Health who were working on TB in Peru, and then ultimately Russia. And because I spoke Russian, I ended up spending a lot of time, starting in 2000, working with Partners in Health in the Russian prisons, and then later creating a community program for care delivery for TB. And TB is this amazing disease because it's about 5,000 people a day die from it, but we've had a cure roughly since 1948. And in Western countries, the rates are really low, like 2 per 100,000, 3 per 100,000. Unless, of course, you're a native Canadian, and the rate is 300 per 100,000. And if you're in South Africa, in Cape Town, it's about 1,000 per 100,000. And if you work in a mine, it's 7,000 per 100,000. And if you're in a Russian prison, it's 3,500 per 100,000. And so you start immediately to see that there's a lot of things that come out of this. Who gets care? Why? Why would the rates be different for these same diseases? You start to think about drug supply issues. You try to think, it just opens up a whole series of questions about health delivery. So I worked with Partners in Health in Russia and later helped them set up their drug-resistant TB HIV program in Lesotho in southern Africa. And because I'd been working on this for a number of years, and by this point we'd treated thousands of patients, I became Partners in Health's rep at the WHO on this committee called the Green Light Committee, which was trying to scale up drug-resistant TB programs around the world. And that, I got to tell you, that was a real eye-opener, because I had always thought of, since working on neoliberalism, I'd realized, of course, that some of these global entities were set up to perpetuate, great power politics and control. But when I got to the WHO, and there was this whole kind of mindset. So I grew up in Canada, where the WHO was looked on really favorably. So when I got there, I was like, oh my God, this is so amazing and all this. And then like about 6 months into it, my friend Joya Mukherjee was like, oh, you're going to hate this, you know. But when I got there, I was like, I wonder why Joya said this. This is so nice and whatever. Anyway, like about 6 months into it, I was like, oh my God, this place should be shut down, because it was really just this, it was basically the entrenchment of double standards and, you know, really relegating people to their place in the global economy rather than the hierarchy of need. And so it just, you know, and TB, of course, it requires health systems. It requires thinking about certain things. Like, you know, they were ignoring children, using things that weren't good for people with HIV. But it was always in poor places, not in rich places. And so, you know, going to these projects as the head of this Green Light Committee initiative, I ultimately probably visited 50, 60, 70 projects. And I realized they're all trying to do the right thing, but there's no tools. It was, you know, just rewind back to Dhaka, you know, to the poor areas of Dhaka. So you can educate people and you can do all sorts of stuff, like whatever that means, but unless you actually have tools to implement, you can't do that. And started thinking really actively about what does it take to implement. So after about 5 years of working closely with the WHO, spending a lot of treasure and time, I realized, along with a bunch of colleagues here at Harvard, that was not going to be the path forward. And the path forward was really thinking about how to engage with communities to treat TB. So we started something called the Zero TB Initiative. And we literally went directly to communities in India, in China, in Thailand, and said, hey, do you guys want to stop TB? And they were like, yeah, we totally do. And then we were like, well, why don't you do what we did in the United States in 1957? You know, active case finding, treatment of all cases, preventive therapy. And they were like, oh, we didn't even know that data. That's not part of the WHO guidelines. And we're like, yeah, but this is what we did, and this is what the CDC says. And we realized it's a new world, right? Because anyone can download the CDC guidelines. And so we started working with communities to really build up TB projects. And it was actually quite successful. So anyway, I've spent the last 20 odd years just thinking a lot about these issues and really thinking about how do you bring equitable care and how do you decolonize our minds so that we can actually work in communities to give care.
Thank you all so much for sharing those perspectives. It's very thought-provoking. And I wanted to start with a question about TB, but also about the bigger issue at hand, which is a vertical approach to global health versus a horizontal approach or a community-centered approach. And you touched on this a little bit, Dr. Khoshabji, but this question is open to anyone on the panel. What is lacking in interventions from the WHO or even the UN Relief and Works Agency, like Brahm had mentioned? What are the approaches to curing disease or implementing healthcare in underserved regions, and what is missing from those approaches?
Maybe I can start. I can give, I know less about this probably than Salman or Brahm, but I could say that from my point of view, because I'm a data person, right? I'm a very quantitative researcher, and my focus is, how can you make a decision without having information or data from the ground? I feel like what's often lacking is that we lack a measurement or sufficient assessment of what's happening on the ground. And there's not necessarily a lot of investment in gathering that data coming from the part of the agencies that are delivering care or the part of humanitarian organizations that are delivering care. There might be some things that are known, and there's a lot of extrapolation done, and that we need, a sense of the local epidemiology or the local issues or the local gaps. You need to be able to communicate with the locals who are probably best able to assess the gaps and problems. And it will otherwise be a top-down, more vertical intervention. And what's needed is really engagement. It's easier said than done, obviously. This is not necessarily easy, but I think there needs to be a clear intent and a clear, prescription that this is an essential part of care delivery.
I think one of the key things that's missing is the idea, right, when you're thinking about this top-down type of approach, is that, there's an issue, you have, individuals and communities who have, these diseases, right, whether it's TB, whether it's diabetes, and thinking about it as a problem at that real downstream level that needs to be fixed. When the things that are really driving these differences, right, when you really kind of start zooming out, are the social, are the structural, are the political, and that actually changing the context in which people live, in which people are forced to live, right, and particularly thinking about populations that I work with, refugees, right, they're there in these camps because they've been dispossessed. They continue to be dispossessed for decades upon decades, and that fundamental situation is first and foremost explaining why the diabetes rates are 18, 19, 20% in these refugee camps, far, far higher. It can't be explained through our biomedical models. It can be explained by just looking at, well, what's the diet? What's going on here? It has to start at that higher level. And I think that fundamental understanding is really lacking in the way we teach about these things and the way we develop programs around these things. And I think getting in with communities, talking with communities, doing that type of research, that type of work, and then building up from there, what is their understanding of why they're getting sick? How do we start to build programs where they're excited about what the solution looks like, right? What is the agency component, in terms of the communities that are in question? And I think that leads to very different types of solutions, and ones that already get at least the possibility of starting to change these situations and starting to change people's possibilities and capabilities for health, right? To think about Amartya Sen's capabilities theory about what people need to really to be free, to be healthy, and things like that. And so I think that has to be that horizontal. It has to be starting in that place of community-oriented care.
So let me just add to this, and in a typical anthropological fashion, I'm going to deconstruct the question, because I wonder if the top-down approach, is it about being top-down or bottom-up that matters, or is it about what you're trying to do? Because if you take the example of this vaccination campaign that people tried to do when we first had vaccines post-COVID, right? The idea was we had these vaccines, and the globe was facing this incredible crisis, and right now we know more about the vaccines, and so just let's rewind back to the moment when they were just created. And companies like Moderna had the opportunity to make these vaccines, Pfizer, et cetera, for the world. And Moderna, farms it out. They don't actually make the vaccine. They farm it out to a company called Lonza, which makes it in New Hampshire, and actually had the capacity to make about 15 billion doses. 12 billion doses for about $15 billion, for example. And this was mapped out by Prep for All and other groups. You had at the same time an international initiative to give vaccines to Africa, COVAX. And COVAX, their goal for Africa was to have 20% population coverage. 20%. That doesn't even cover the people with diabetes and hypertension and all the risk groups. Because if they had said, we're going to cover all the risk groups and et cetera, that number, I don't know what the number would have been. Let's say it's 53% or 68% or something. But they came up with 20%, to which people said, wow, that sounds like it's full of coloniality and doesn't sound very good. And they said, okay, you're right. And then it went up to 40%. It ultimately never happened. But that was a top-down approach. And so you look at that, and if you deconstruct that, you say, what if we had gone to villages and said, how much vaccine do you want? And they were like, I don't know. So it's not about grassroots, or in that specific setting that I'm giving, that example that I'm giving you, it just makes me wonder, what were your goals for others? And since you quoted Paul Farmer at the beginning, he had this great quote, which said that we're constantly being conditioned for scarcity on behalf of others. Right? And so nobody is saying you need to have 40% coverage in the US. I mean, Tony Fauci was saying 70, 80, right? So we were doing this for other people in Africa. So again, who should get the care, who should not, et cetera, et cetera. So it makes me, I think the biggest gap here when you're looking at this is this lack of ambition to actually give healthcare to others. And then that obviously leads to this thing where we say, well, there's not enough money. These places are poor. And let's just change the language a bit. Are places poor or are they impoverished? So Sierra Leone is impoverished because plane loads of diamonds fly to Belgium every day. It can't be poor. South Africa is impoverished in impoverished parts of it, but there's the gold and platinum and diamonds and all sorts of things leaving. So it's not poor, right? So like when you start to look at this, you start to like then question some of these things because the solutions depend on that. If I say X is impoverished, all they can have is like, avocados to treat HIV, you'd say, wow, that makes complete sense. But if I tell you, we're actually extracting from these places, extracting labor, harming these people, and on top of it, we're only giving them avocados for HIV, you then view the problem differently and say, wow, shouldn't we sit down and try to do something differently? And that's where top down, bottom up, it's about what ideas do you have to actually give health to the community and the community seeking health for itself coming together. So COVAX is a great example where at the time, African countries wanted vaccine, but the international community wasn't willing to do more than the bare minimum.
Can I give a follow-up? Salma, can I just do a quick follow-up on this? Because I think you're obviously making everyone think very deeply about these issues. And it's also really true that there's a lot of ways in which we kind of disable our ability to help or fix the underlying issue. But I'm also wondering if we assume that the WHO and the COVAX runners have the best intentions, and if they had the best intentions and yet they put the initial ridiculous goal of 20% coverage for the vaccine, do you feel that this is because they have somehow internalized a mentality that we simply can't do more because it's really, really hard or it's really, really expensive? And how do we fix that kind of internal, I don't know, for the lack of a...
No, this is a great question. I think you're on the mark, right? We've internalized something, and the question is, how do you change that? And, again, I'm spoiled because I got to work with Partners in Health for so many years where they were doing implementation work, trying to bring a high level of care in communities, and the answer was that, well, you do it and you show that it can be done. And I'll just give you a concrete example. When we went into Lesotho to treat TB, HIV, Partners in Health did, that was a point where 70% of people, so the 25% of the country was HIV positive that were being measured. People were working in the mines of South Africa, coming back with TB, their families were getting it, so the death rate from TB was very, very high. It was like 70 or 80% death rate. And they had drug-resistant TB and other things. And to diagnose drug-resistant TB, you need a laboratory. At that time, you needed a laboratory. So we said, oh, yeah, we'll build a laboratory, and went around to different groups of people. And the US CDC said, oh, man, it's going to be brutal. It's going to cost you millions of dollars, and you just, I don't know if you can have a lab running in this place. It's going to be really hard. We went to the head of the South African National Lab, who later became a very close ally, but at the time said, I don't think you can do it. There's not enough trained people in this country to do this. Like, you won't be able to have a lab, it won't be able to run, et cetera. It's going to cost you X amount of money, et cetera, et cetera. To the point that we were like, I guess, how are we going to do this without a lab? And we started sending samples to South Africa and trying to figure out another way. And then I bumped into a guy named Giorgio Rossino, who ran the Foundation for Innovative and New Diagnostics in Geneva. And I presented this problem to Giorgio that we need a lab. He'd grown up in Ethiopia. And he said, he's like, when do you need the lab? And I was like, I don't know, yesterday. But everyone is saying that it's going to cost this much money and we can't train people. He's like, of course you can train people. I'll send a guy to live there for a year. He'll train all the people, work on the SOPs. You hire local Basotho people, and then you'll have your staff, and you'll be able to run this lab for many years. And I was like, yeah, but we don't have the money. Everyone's saying it's going to cost millions of dollars. And he's like, no, I can get this equipment. This equipment, it's probably going to be around $500,000. But I need you to do make sure that the carpenters can put things in and blah, 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 blah. Anyway, we had a lab running in 5 months. We started doing genetic testing, Hain testing. We started doing, the gene expert. We had cellular culture working within 6 or 7 months. And that lab exists till today. And our colleagues from South Africa later became part of the WHO laboratory initiative. And she used this as a model to expand laboratory capacity in Africa and Asia. So you can do it, but I think what we have to do is overcome the barrier. And of course there's challenges, but if you look at the fact that during this war, this constant war that the United States has had in the Middle East and Afghanistan, we've had Burger Kings in Kandahar and places like this. You've got to say to yourself, wow, if I can have a Burger King in Kandahar, I can obviously have a lab that's going to serve millions of people in Lesotho, in Maseru, right?
So much. And I wanted to pivot slightly and pose a question about agency. to all of the panelists. I think a lot of the issues we speak about sort of really resonate to perhaps many people in the audience, definitely resonate to me as a matter of not asking the right questions, not collecting the right data, but even a broader disregard for the opinions, the perspectives, and even the decision-making capacity of vulnerable communities. And for each of you who has worked in one way, shape, or form, one way or another, with vulnerable communities in the Arab world, in areas outside of the Arab world, what can researchers or those who are coming in to do global health work, what can they do to really incorporate and honor the desires of the communities they work with?
I'm happy to start. So I think you're touching on an incredibly important issue, and it's not only agency for the communities, for those of us in the West doing research in the, in the rest of the world or parts that we identify as resource limited. I think we all do it with really good intentions, and traditionally, however, there's a very heavy colonization of that process whereby, the West is coming in with resources and setting the agenda and kind of deciding, this is what NIH wants to fund, so this is what I'm going to do. I kind of maybe I consider what you need, but maybe I won't, depending on what NIH is going to fund and what my progress report has to say, or something like that. So there's obviously this push and pull, and then researchers don't necessarily do it malignantly. I mean, I truly believe that everybody has good intentions in every context, that we are all trying our best. However, I think what we need, this is sort of a multilateral issue. It's not just on the level of the researcher, but we need the funders, we need the IRBs, we need all of the people who are managing and working around research to motivate the engagement of communities and setting agendas that make sense to the local epidemiology, that we not only kind of have researchers coming from the West into that other parts of the world, but that you engage meaningfully with local researchers, and that you build capacity, and that you train them, and that you have a meaningful exchange, so that you can actually not only contributing to science and knowledge and expanding what we know about the particular issue that you're tackling, but you're also having a positive impact on that community, and that you are actually potentially training a next generation of researchers who can then themselves better their communities. And so I think that from my point of view, that needs to happen. And it is happening. I mean, there is more and more attention to this issue, but there's still a lot that needs to be done.
Amazing, thank you.
Yeah, and I couldn't agree more. I think that aspect of getting the involvement of folks on the ground, right, in the research, thinking about the education piece, that's so key. I mean, the way I've seen it in the work that I've been involved in, it's what we try to do is we're training community health workers, folks from the refugee camps, to actually be the point people that are working with the patients towards their health, right? So it's that idea that as physicians, we sometimes forget that actually we're just one point person in a much larger care ecosystem, and in fact, for diseases like diabetes that are chronic, that require so many different touch points, so many different day-to-day decisions, right? The physician and the physician's knowledge base is not even that particularly helpful, right? You're not spending that much time with the patient. You're not there with them during all their moments, throughout the days. And so thinking through that agency question, I think is so key. And you realize that actually communities have all the tools, everything they need in these contexts, right? Even in the most marginalized, oppressed conditions. For example, a place like Ida refugee camp, where you have the most tear gas exposed community in the entire world, according to a UC Berkeley study, that they have actually the tools they need to manage diabetes effectively. And actually, we published that study this summer showing that they significantly reduced hemoglobin A1C compared to control patients who didn't have a community health worker working with them, at levels that are, better than the best medications that we have for diabetes, right? That's been shown elsewhere in the world at other partners in health sites, but even in, urban refugee camps experiencing chronic violence, you can see that kind of thing. So, there's lots of, I think, different ways that agency shows up in those spaces, and I think that's a really particularly important one.
Bram used a phrase earlier. He when he was describing his work, he said, "I was there for this number of years, and then I worked in solidarity. We started working in solidarity with community there. And I think that that's kind of the key thing, because when we think about agency, the idea is that your people are going to know exactly what they want. And I remember confronting this in Tajikistan, where we'd be in these villages, and the former Soviet Union had some of the highest education rates. So you were talking to people that were highly educated, that were back in villages farming, but they were trained as lawyers and doctors and what have you. But when you talked about complex things like, well, how would you feel if antibiotics were being sold? Then they were just like, well, I don't know, how much would they be sold for, and who would, what would that do to death rates, and how much does, what are people dying from? They were asking really, good questions that, you need to kind of like an outside lens, like the government has those data or other people have those data, right? And so you realize that there's got to be this input from the community, but to ask the community to define exactly what's done is sometimes difficult because you don't have full information. If I ask everyone here, if you hurt your knee, do you want a CT scan or an MRI? I hope you choose an MRI. But if you don't know, you may say, well, I don't know. You're a doctor. Why don't you tell me, right? And so I think that you're in this situation of how information flows. And so, I think that part of it is kind of raising this level of conscientization of what's possible and what can be done. Because I think you raised the question, what does working in solidarity with somebody mean? If you're living in Roxbury or Dorchester and you work a 12-hour day and you've got kids that may or may not need healthcare, working in solidarity might mean that you do what Nancy Oriel at Harvard has done and set up a family van that goes into these neighborhoods, right? And when you go into the neighborhoods, you can give care, obviously to families, but children and et cetera, right? So it's like not some earth-shattering development to actually have a mobile van, but it's incredible because it's actually what the community needs, right? And you're talking about having a community health worker in a refugee camp. It kind of stands to reason that people who are vulnerable would need that extra level of accompaniment that one needs. And in fact, I think probably most sick people need a level of accompaniment, which is why we have such bad outcomes in the United States. So I think that when you're thinking about agency, I think we should tie it to the language you used of solidarity, because you want people to have agency over their own health, but they have to you have to create programs that give people the tools with which they can have that agency. So if you tell somebody eat well, but they live in a food desert, if you tell somebody exercise, but it's 50 degrees outside and there's no place to go, like that doesn't build agency, right? That goes back to my Bangladesh story. You tell people, oh, you gotta have clean water. You should boil water. And they're like, we're living on raw sewage. Like, what are you talking about, right? So they don't say that, actually, incredibly. People are incredibly polite, but I hope they're thinking that, right? So that's the thing. Like, how do you actually work in solidarity so that that agency in the community can actually, come out?
Yeah, really excellent points. And I think some of this also ties back to agenda setting and funding. And I was curious to hear from each of you a little bit about what it is like concretely to collaborate with funders or with organizations that are providing the funding, because as much as we would all like to do work like this, there is a bottom line. There needs to be funding for these initiatives. So what are some of the challenges you faced in setting up collaborations and really getting on the ground or having those people there to be there longitudinally?
So I think that you're asking, again, at the risk of sounding like Salma and deconstructing your question, you might be asking two different things. I think so. There's collaborations with, potentially people on the ground who help you actually get the research done, and then there's also the funding, and the collaborations may or may not, be involved with the funding. The funding, I think, is a huge issue because. For those of us who work in global health, we all realize, especially in the shadow of things like the Gates Foundation, that money really talks and it sets the research agenda. And sometimes when those funders kind of have evaluated and understand what's needed, that's great, but sometimes they don't, and sometimes that ends up kind of funneling research and resources and manpower and you name it down kind of a set of paths that actually isn't very fruitful. And that's really problematic because if you think about the opportunity cost of where those funds could otherwise be and what you could do with them, it kind of breaks your heart as a researcher who's like trying to get something done and you have an issue and a problem that you feel passionate about. I think that it's for someone starting out in the field, it's very challenging. It takes sometimes years for you to kind of be co-mentored and supported to get to a space where you know people feel confident in providing you with funds for you to conduct that work on the ground. And I personally, you know, find that I let Bram and Salman speak about implementation and, you know, and kind of the healthcare delivery type of research, which isn't necessarily what I focus on now. But I find that the questions I need to ask when I'm working in a global health context, they always have to have, you know, the requirement is that you have to be able to generate generalizable knowledge from that research. And sometimes your generalizable knowledge is generalizable to that community, but not necessarily to other communities. And that kind of research, at least for NIH in a scientific context, is harder to justify. And they might tell you, oh, you know, you need to go to a public health delivery type of program. You can't come to the National Institute of Allergy and Infectious Disease and ask for funding for that. But it's something we all grapple with. And I find that at least sometimes I see my role as this person advocating for the problems that I think are important. And so my role is to just really get better and better at advocating for funding for those problems that I feel passionate about. And I invite all of you who feel passionately about a problem to really develop a deep expertise in it and then be able to advocate for that problem by bringing in funding, by you know, doing the work. And usually you have to do the work first, show that you can do it, and then you can actually get, you know, the real funding to do a really large, impactful project. And it's kind of incremental. But it is definitely a path worth pursuing and an incredibly rewarding career path. And that's the case for me.
When I think about like global health delivery, you know, implementation, funding, you know, some of the most beautiful and incredible examples, you know, and thinking about MDR-TB, right, in Peru, right? If you read that first study, right, that Paul Farmer and, you know, and Jim Kim, it was in BMJ or something, you know, 20 years ago. I mean, there's a couple dozen patients, right? You know, they started very small, right, or their initial study in Haiti treating HIV, right, in Partners in Health. And but through that proof of concept, through that dogged determination, through the fundraising that was very much sort of grassroots, you know, reaching out, asking, they were able to then, you know, say, we're going to do this, we can do this, we should do this, we must do this, and then, you know, put it out there to the world, and then, you know, opening up these opportunities. You know, a similar example in the community grassroots organization that I work with in Ida Refugee Camp, Laji Center, was an amazing person there, Shada Alaza, had been determined to work on water. The water situation was terrible in the camp, right? There were tanks on all the roofs, right? And it was contaminated. She showed it was contaminated with E. coli and other bacteria. And so partnered with some folks in solidarity from Tufts University to essentially clean up all the water in every tank, right? 5,500 people cleaned the entire thing and actually then brought it to the UN, right? Brought it to UNRWA and said, hey, here's what we've been doing, right? And this was, again, all through kind of grassroots funding that was happening at a, you know, pretty small scale, but enough to do this. And then the UN took over that work from there on, being like, here you go, this is possible, this can be done, and go from there. So I think there's also this element that, you know, if you're tenacious enough, you really dream, that it shouldn't necessarily be seen as a barrier on the implementation side. You know, you start at something where you are with the community you're with, and you can start to build it with pretty limited funds. And if the work is meaningful and really, you know, making a difference, right, then other opportunities start opening up.
Yeah, and just to add to this, you know, when we started the Zero TB initiative, we initially called it the Zero TB Cities Initiative because one of the things that we were thinking about was exactly this funding thing. And so we started doing an analysis of where funding flows happen in different places, and it turns out that municipalities have independent funding. They also have independent forms of accountability, right? Because you know where the mayor lives, and you know where the mayor's office is, and so you actually have more of a back and forth than dealing with like some central government or a state government. So we started like kind of doing this political and financial mapping, and realized that if you could do pilots in places that had some money, they would grow, and then you'd create these islands of elimination. So for example, when we talked to the Chinese government about where to start the Zero TB initiative in China, they themselves said, a great place would be Shenzhen, because they have a lot of resources to be able to expand a program like this, right? So even they knew. And the same thing, in India, a lot of cities were like, yeah, we don't have the money for this. But one city, Chennai, said, oh yeah, we really want to do this. And so I think that if you can get pilots off the ground using seed money, and then you can tap into other resources. Because I haven't really come across people who are sick that don't want to be better. And I haven't come across, I mean, it's true, right? Like it's obvious. And I haven't come across communities where if they can do something, they won't. Like I know in Chennai, for example, when we were thinking about how do we give food to people who are have food insecurity, even the mayor himself was like, we've got these kind of soup kitchens in different places. Would that help? We were like, oh yeah, that would help a lot, right? So like they've actually had all these municipal resources that were not being tapped into. So I think there's ways to do it. And then there's some settings that are very resource depleted. And thankfully, I think there's good people in the world that really want to help in some of these places. Our friend Paul Farmer, the late Paul Farmer, was very good at tapping into these resources, like talking to people, and they had confidence in him and would give the resources. So I think there's also like tapping into people that want to be transformative in the world. Because Zero Cities, by the way, we got our first huge grant from Johnson & Johnson, of all people. And it was a former student of mine that had become an executive there and called me up one day and said, you used to talk about TB in all these classes. Are you interested in doing something? And they ended up giving us $6 million. Yeah, it makes you want to teach, right? So, at the end of the day, like she helped us and we got this off the ground. But sometimes it's like private donors. The work you're talking about in Peru was funded by Tom White, who owned a construction company in Boston, and was like, I want to do stuff to change the world. So if you find people that are really interested in being transformative in the world, that's another piece. So having a strategy for funding where you integrate in communities where there are resources, bringing in the right types of seed money. And of course, Maha's talking about research. A lot of our stuff started as research projects. Like we knew we wanted to implement X, Y, and Z, but we started it by getting NIH funding to like map out what's going on in the community, which is really, really important. Say, in the case of TB, looking at transmission dynamics in a community. But once you've mapped it out, think about it. You can activate human rights groups, you can activate other people, you show the extent of the problem. So very recently in Peru, we were working in a community where they said their TB rate was 70 per 100,000. And we put in mobile x-rays, kind of like the mobile clinics, but mobile x-rays to screen people. And at first they were like, well, yeah, you can do it, but you're not going to find that much more. And so to test the machines, we set it up outside a mall in one of, in a poorer part of Lima. And on the first week or two, we ended up seeing rates of 600 per 100,000. The national rate, like in that community, was supposed to be 70 per 100,000. So we thought, oh, this is odd. Like maybe we're over-diagnosing or whatever. So we checked and we weren't. And then some military cadets came by. They happened to come to the mall. And we said, oh, let's screen them. And they had a rate of TB of 1,000 per 100,000. And it's interesting because they looked healthy, et cetera, but they had TB. And so then the military started demanding of the Ministry of Health that they get more of these vans to screen more people. And now the government is into buying these vans and screening people, right? So it's really been interesting to watch the genesis of this, that if you can actually show that this technology works, more people want it.
Thank you so much, and I'm mindful of the time. I think we have until 2:45, but I wanted to close out with one last question for each of you before we open it up to the audience for questions. And the question I have is, what does the future look like for community-centered care in global context, and what advice would you give to those members of the audience who want to be a part of building those futures?
Maybe I'll skip this one because I feel like it's a little outside my expertise.
I could project the future and say all is looking bright for community-centered care. It's such a good. It's so contextual, right? And I think we're seeing a lot of global trends that are discouraging in a number of cases. But I think it's really important to hold on to the examples that are exciting in that work. I think there's a lot of great critical scholarship that has really, led by amazing anthropologists and people like, Salman, that really help us think better about what care should look like, how we've been giving it, how we've been approaching it, who's involved and how. And so I think that we have the tools that are necessary. And so it's really, it's up to us. We know what to do largely, I think, and it's, basically that opportunity is there. And, in places like where we've been working, right? I think that's really the solution right now because, Partners in Health's model, for example, is public health system strengthening, right? Well, what does that look like in the case of military occupation for half a century? What is the public system, right? You have a temporary UN agency providing health care, right? You have, a Ministry of Health that's tied to a government that is, maybe not going to be there forever, right? And so what I think that looks like, at least in the context of Palestinians, that we're working with is, is to give them as many of the tools as possible, right? One of the things they wanted from us was we just want to know our own data. We want to know about, I don't know how my diabetes is doing. No one tells me, I haven't heard it, right? So it's like, we can put Kobo Toolbox on the phones of our community health workers. They can collect that data. They can share it with their patient every time they see them, right? Once or twice, a month, whatever it might be, depending on how well controlled they are. And so I think, at least in the sense of these types of contexts where, the typical health system strengthening is not possible, really what that looks like is putting more of the tools, putting more of the information, putting more of the control as much as possible within communities themselves for whatever, political solution is or is not on the horizon, right? This will be valuable regardless of what is to come. And I think thinking through community-centered health in that way potentially could have a lot of value.
I think that's exactly right. Let me just pick up on that. If you start to look at what's about to happen, so we just obviously all went through COVID, and COVID was kind of like an X-ray. It showed us all the weaknesses in our health system. And the basic weakness, of course, was our ability to diagnose people and deliver care and supportive services in the communities where they live and work, right? That was the simple thing. That's exactly the problem with TB. That's exactly the problem with hepatitis C. That's exactly the problem with diabetes. That's exactly the problem with mental health, right? So you just go down the list, and of course there's things you need a hospital for. One of the great things of the 20th century was that great hospitals were built, because if you break a bone and it comes out of your skin, if you don't get a doctor to fix it and take antibiotics, you're going to become septic and die. So you need a hospital, right? If you have appendicitis, you need a hospital. So there's things that you need a hospital for, but there's a lot of things you don't. And if we look at what's coming in the years to come, in the years ahead, we've got 700 million people are estimated to have diabetes by 2040. That's crazy, because you're going to need renal replacement therapy, you're going to need eye care, you're going to need pneumonia care, heart care, et cetera. The burden of mental health is largely unmet, in the world. It's only a small proportion of people that have the need are getting the care that they need. And you go down the line on any of these diseases, and the volume's going to go up. So if we were really kind of broken, our hospital and health systems were broken by COVID, we've got a huge reckoning ahead, right? So I think that it's just absolutely imperative that we move to thinking about how to diagnose and treat people in the communities where they live and work. And unfortunately, we have huge entrenched interests in maintaining a hospital-based system, because it makes a lot of money, not only here, but around the world. And of course, hospitals are important, so you don't want to defund that. You want to have that as a backbone. But I think we're going to have to really think about how to expand care into the communities. And it may be community vans, it may be diagnostic centers, it may be that you offer certain facilities at the local 7-Eleven. And you already see this developing, right? Minute clinics, et cetera. In countries where you have privatized healthcare, you see minute clinics. In countries where you have healthcare as a human right, like say Canada or the UK, you see a lot more urgent care clinics in other places. And so you start to see that people are recognizing that you have to bring it closer if you want to actually have the right care. So I think it's an imperative. So the future, may not be rosy, but we're going to have to face it. Because if we don't, we're going to have these incredible gaps.
Thank you all so much. Thank you. And I wanted to open it up to the audience if there are any questions. I think we have a question up there. Sorry, can I pass you a microphone? I think, yeah, so our media team can catch it. But proceed, go ahead.
Can you guys hear me? Okay. So just quickly, if I was just curious if, from your experience on regulating basically volunteerism, white savior complex, this trend that's happening, and your experience on affecting your work, which I think is a little bit more, I won't say important, but more impactful, because unfortunately there's this trend, I would say almost 80%, for example, of medical school applicants are spending tens of thousands of dollars going to Africa, India, and they're not really doing much work. Some of them are even hindering care and providing, I think these gaps in giving communities health care. And I think it's like a deterrent, because when I was in Greece, for example, I would see, people like these Syrian refugees on multiple antihypertensive medications that different groups would come in and give them, and I'm like, what's going on here? And it's this trend, and it's this like white savior complex that I seems happening, and it's going unregulated, and I think it's becoming kind of almost mainstream at this point. So I just want to know from your experience, has it hindered your care, your work, and is there a role in regulating kind of this global healthcare or this need? Because I think at the end of the day, all of them are well-intentioned, but I just feel it's more hindering than anything.
Thank you. Thank you for that question. Is there anyone on the panel who'd like to tackle that? I think it's an important one.
Well, yeah, this is a really important question. And I know we've got limited time, so I just want to, there's so much to unpack in what you've said. But just to dive into it, so we want people to work in solidarity with each other. And you don't want to promote like kind of global health voyeurism, but you also do want to have the witnessing of the suffering that goes on in this world so that people can understand and change. So there's like this balance, right? And I'm just thinking of places that have highly regulated the work of NGOs, for example, like Rwanda, where they've said, well, look, this is our national strategy for X, Y, and Z, and if you come, you're welcome to come, but you have to work within this national strategy. And that has proved to be very successful because, everything, like a lot of things become, aligned with what the government and what the local communities want. The part that kind of gives me pause is, Paul Farmer used to joke, you wouldn't send somebody for 2 weeks to work at a nuclear power plant. Why would you send them to, set up a health system? And I guess therein lies the problem, right? Like a nuclear power plant is a very well-organized, hopefully, a very well-organized entity that you wouldn't be able to just walk into for 2 weeks and just do whatever you wanted. And I guess in a way, this speaks to the fact that, a lot of humanitarianism that we've seen in recent years has been dealing with an emergency, has been stopgap, and has not actually built health systems that are, that are permanent or semi-permanent. And so what happens then is that somebody else can come in and change it or just, on a dime flip it. If these things were semi-permanent or permanent, you wouldn't be able to do that. So I just think of when we were doing drug-resistant TB treatment in Russia, a superpower, we didn't just walk in and we're like, hey, let's do this. They had a medical system, right? And they were like, we were like, we think that we can bring down rates in the prisons if we do this. And there was a discussion, and there was a national high-level working group, and and everything happened in gradations, right? So that's on one end of the spectrum, and the other end is what you're describing. So I think that we don't want to throw the baby out with the bathwater, because I want more people to be working in solidarity with people in other parts of the world. And it's not just, I want Indian elites to be working with the poor in India, and I want African elites to be working with the poor in Africa and India. And like, so it's kind of like a global solidarity thing. So there's got to be a lot of thought given to this, how we what the regulation would be and what we're trying to get out of it. But I see the point you raise. It sounds terrible.
I wonder if we can squeeze in.
Can we go a bit over?
Okay, let's squeeze in one more question. Oh no, but I have to pick. I think that's
a good idea.
Great idea, amazing. So we'll take a question from you and then from you. You go ahead. I don't know where the microphone went.
Maybe you can.
I think you can.
Yeah, just come to the mic. Yeah.
Yeah. I'll try to summarize. Yeah.
Hello? Perfect. Hi, thank you so much for the wonderful panel so far. My name is Brahim. I'm a community health worker trainer at the Public Health Commission in Boston, so I really appreciate the focus on community health workers because, they're often overlooked. My question is in regard to actually, operationalizing and implementing community health worker systems, because even working in Boston, where, there is a very intense health system and a big focus on community health, it can often feel like pulling teeth to get proper funding and support for the CHWs. It's a very underappreciated field of work. So when you're dealing with international contexts where, due to Western approaches and colonialism, you're barely giving them any resources to begin with, how do you advocate to get these CHWs the resources they need to do their work? And moreover, how do you continue to build capacity once you're gone?
Amazing. That's an excellent question and an important one. And then we'll also hear the next question, try to synthesize them, and finish on time.
Thank you so much for this inspiring panel. I'm a pediatric neurologist. I'm a Palestinian. I work with Bram, and he's my friend. And, I hope I will get to know you too. I'm having a problem. The problem is that I really want to implement the community health worker model in providing care for children with autism, with global developmental delay, with mental health issues. The problem that I'm having is that Western medicine is extremely regulated, needs extensive years of training, and very expensive. And I'm trying to figure out how to develop a community health worker model that respects the culture, respects the people and the community without being arrogant and without saying, well, we can't do that because it's very expensive. Just like the lab story that you mentioned, and I'm asking this question, hoping to find like-minded people in the audience, maybe, to even discuss this further outside of this panel. Thank you very much.
Thank you so much for that question. And I think both of them follow similar threads. I wonder.
Yeah, I'm happy to start at least. I mean, when we first started working with community health workers in Palestine, actually the UN told us, like, it's not going to work. Actually, they said that, community health workers as a model doesn't work in the Arab world, doesn't work in the Middle East. People won't accept it, right? And, in Palestine, of course, is a very highly educated population, and the theory was that we were told was like, well, they're going to want to see doctors, they're going to want to see nurses, and not community health workers. So I think, we're like, well, that hasn't been our experience, right? We've been doing focus groups with the community. This idea came out of those focus groups. And so, we'd already basically started at that point. And we had, we lost 0 patients in our first 2 years of working with people. They were extremely, extremely happy to be working with community health workers towards their health. And so I think part of it is then, of course, the advocacy. It's disproving these narratives wherever they may be coming from, whatever colonial elements may be underpinning some of the ideas, and showing that it works. And I think, there is a lot of data out there already. So like, it doesn't mean, I have to sit there and be like, well, I'm going to start from the bottom up, right? Community health workers have been shown in many different contexts. I think in the United States, to get at the first question, it's almost harder because of the way our health system works in some ways.
Billing for Medicare.
Billing, yeah. In a lot of states, it doesn't work, right? I actually work through my work at Partners in Health with a a network of community health workers in Ohio, and there they can get reimbursed through Medicaid. And so there's an incredible group of community health workers I've been working with for the last year and a half around COVID work with their patients. And so it's definitely doable, and it means firing on all different cylinders of picking all these pieces together and sort of really creating a movement. I think it's as much as anything, it's a community organizing initiative. We have to build a movement of people who say, we know this works. This is the model that we need in a setting of deep, deep inequality and injustice that we have in this country and all the places that we're talking about. And I think in dreaming it up, and I think Karama with that work and that model, I think I'm sure you're going to come up with something really, and it's just, having people to sit there and support and be like, yes, of course, maybe this hasn't been tried before in this type of care with children, but, why shouldn't it, right? And then, if you have this neurologist Harris be like, I support this model, and this, and then, start doing it and see what happens.
Well, thank you so much, and thank you to the audience members who asked questions, and of course, thank you all for joining us. I think this was a wonderful discussion. And I hope to see many of you at tonight's dinner fundraiser event. See you all.